at World Health Assembly. Again, I'm Lois Pace with the Global Health Council. I serve as their president and executive director, and I want to thank everyone for being here. A lot of you are our members who have joined us for this week of activities. I hope that you've had a solid experience. It's certainly been great to see everyone around town taking it all in, but I'm sort of sad to see it all end as well because it's been such a busy, productive time. I'll be looking forward to WHA 72 in no time. But we're here today to have this conversation about a topic that's come up consistently over this past week, this topic of universal health coverage. And, you know, there's been a lot of rhetoric around it, not just this week, but in the past few years, and all of that is good. You know, we appreciate the goals that have been set, the charge or challenge that's been put before us. But really, I think an outstanding question a lot of us have is still what the way forward really is for all of us in UHC. We really recognize that more than just a notion, it's really important that we provide access and affordability to people in need. And really, I think what we want to do today is have a conversation not just about what's needed, the outstanding gaps, the challenges to achieving UHC, but actually what's happening. We want to feature work that's happening on the ground that's really getting at that service delivery, really getting at that financing, and really showing all of us a way forward so that we can chart our own course to achieving this lofty goal and find our own path, each of us individually or organizationally, towards UHC. So with that, I would like to bring up our first speaker who's going to offer some welcome remarks. We have Mr. Alex Azar here joining us. He is our U.S. Secretary for Health and Human Services, and I very much appreciate his presence here today, especially since the U.S. has been thinking about this issue of healthcare and health coverage over time. I know that this week as well, Mr. Azar has attended various events and shown our leadership, or our government's leadership in this space, including our role in global health security and a number of other areas. So again, thank you very much for your time here this week. I know it's been robust for you, but we appreciate your presence here today. And with that, we'd love to have you come offer remarks. Thank you.
Well, Lois, thank you very much, and thank you to the Global Health Council, Living Goods, IntraHealth International, and Frontline Health Workers Coalition for inviting me to speak at this very important event. As the title of this session reflects, there are diverse pathways toward the worthy goal of universal health coverage. The United States believes each nation's healthcare system must be accessible by all of its citizens. That means providing comprehensive geographical coverage and ensuring access to care, especially primary care. Each country's efforts towards achieving universal coverage and universal access to care need to be flexible as circumstances shift, new challenges arise, and the nature of healthcare changes. Now, we applaud efforts to encourage universal coverage and access, understanding that this need not only happen through government interventions. Given the diverse range of national contexts and priorities around the world, countries should choose their own way. Our choices in the U.S. will differ from Japan's, or Brazil's, or Zambia's. Systems around the world rely on a mix of private and public systems to deliver health care. In many cases, private delivery systems offer more responsive services and greater efficiencies in care, and they play an important role in nearly every country's health system. Private businesses can also contribute to universal coverage and better health by financing or providing health services, including preventive services for their employees. But what all countries need is a strong primary health care system. It's crucial not only for the prevention, detection, and response to epidemics, but it is also the key to achieving healthier communities. The United States, through its critical programs, such as PEPFAR and the President's Malaria Initiative, build up the capacity of local health systems. This capacity not only brings malaria, HIV, and TB testing closer to the patient, but it also builds an infrastructure that fosters health promotion and education so that families and communities can live healthier, more productive lives. Currently in the United States, we're engaged in efforts to secure better value from our health spending, which will help us provide more access to high-quality care. Many countries endeavor to pay for value in their health systems by central assessments of the cost effectiveness of various interventions, something the United States has worked to do as well. But we believe there is an indispensable role for consumers and patients and the private sector in assessing and securing this value. Academic research can only tell us so much. Market forces and patient choices can often ultimately be more effective and efficient in determining value. Recently, I laid out 4 particular areas of emphasis that are going to be vital to empowering patients in the United States to secure better value from their care. First, we need to give consumers greater control over health information through interoperable and accessible health information technology that they truly control as patients. Second, we need to encourage transparency around price and quality from providers and payers such as private insurers. Third, we need to use experimental models in the U.S. government health insurance programs that we have to drive a focus on value throughout the entire healthcare system. Our government-sponsored programs, what are called Medicare and Medicaid, are so large that they can truly drive change throughout the system, impacting the private commercial part of our health insurance market. Finally, we need to remove various government burdens that impede this value-based transformation, especially ones that get in the way of coordinating care, integrated, collaborative approaches to patient care delivery. I have every confidence, based on my own real-world experience, that this will bring constructive disruption to the U.S. healthcare system, and it will greatly improve the value we get from our hybrid public-private model in the United States. The American healthcare system has a great deal to be proud of. We drive much of the world's innovation, and the quality of care provided in American hospitals is peerless. But it is expensive. The Trump administration is serious about making healthcare dollars go further while still providing the highest quality care for the largest number of Americans. Getting more bang for the buck, as we say, will be a major step forward for universal health coverage and universal access to quality care in the United States. We look forward to consulting with our friends overseas in this endeavor and learning from you about how public and private actors can work together to put patients in charge of securing quality care. Each of our systems has much that it can learn from each other. Our ultimate goal is for the United States to pioneer a new patient-driven, value-based model for healthcare which will expand access and support the next generation of incredible innovation, not just for our citizens, but for all the citizens of the world. Thank you for your time and attention, and I look forward to our dialogue today.
Thank you very much, Mr. Secretary, for your remarks and for joining us this morning. We very much appreciate it. So now I would like to bring up Ms. Kwanele Asante to offer us a very important patient perspective. You know, we think about UHC as a mechanism or a goal, but really we have to remember that people are very much at the center of this objective. And so, Kwanele, we're very happy to have you. We know you've been very busy this week sharing your story, but we're happy that, that you will do so one more time for this event this morning. Thanks.
Good morning, ladies and gentlemen. I must say I'm really relieved that the Secretary of State left. You know, because with respect, he's a government official, and there are beautiful things to say. My task here today, and I'm very thrilled, is not to be smart to offer you solutions. It's just to help us just pause a little bit and reflect what we're talking about when we say universal health care. I was very intrigued that Secretary Azar said access to the greatest number of Americans. That is not my understanding of universal health coverage. We go back to Alma Ata, 1978. We said we will give universal coverage. And as a patient, I'm here to say we are late, we're failing. There's too much of the good English words. We need to distill it to real things. What patients want are not political commitments. We want to see clear ways, clear pathways of how you are, as a world global health community, finally going to bring us to universal health coverage. We need to see funding that's devoted, that we don't have global disparities, and we don't have in-country disparities, and we don't have patients not have access to safe medicines. We're not talking about just access, we're talking about access to quality healthcare that is timely, that is people-centered. The global patient community is really now tired of the rhetoric. We need to see action. This morning I haven't focused on the private health sector. I need you to come to the party. We have been having this debate around access to medicines. It was part of the promise of Alma Ata as one of the pillar stones. And we are sadly sitting in a world where some countries use their political might to intimidate developing countries and least developed countries from using their TRIPS flexibility so that we have enough medicines. So this morning I'm going to sit down, I'm going to listen, and I'm asking you, please make it concrete and give us a time frame. With respect, Mr. Politician, people don't need the extra words anymore. We need change. We need real change now. Thank you.
You guys see why we love her, right? Speaking the truth. So with that, I will invite up our last speaker in terms of welcome remarks, the Honorable Minister of Health for Uganda, Dr. Jane Aceng. And I know that she is particularly committed to seeing better access to quality health care, especially given her background as a physician. I know that Uganda has led the way in many areas, and so we would love to hear from you what action you have taken to make UHC a reality. Thank you.
Well, it's tough talking after a patient. And I want to agree entirely with her that patients want action, not words. And usually in government, we sell words, unfortunately. So allow me first of all to thank the Global Health Council, Living Goods, and the Health Workers Coalition for inviting me to speak here and share some insights on what we are doing in Uganda in the journey to universal health coverage. We all agree that there is need for us really to ensure that everybody receives good health care, and it is not only about care in the health facilities. Global health coverage, universal health coverage also encompasses public health. And as you're aware, many of our countries are still struggling to ensure that we eliminate communicable diseases, we make sure that primary health care is accessible to all and of good quality, and we also address the issue of tertiary health care in a comprehensive manner. And therefore, as the Secretary of State said, there is no prescriptive path for any country to universal health coverage. And all our countries have to, get a way of getting there using the resources available, but ensuring that there is equity and accessibility for everyone without leaving anyone behind. Our first step on the journey towards universal health coverage in Uganda was the introduction of the National Minimum Health Care Package in 1999. That is implemented up to the lower health levels. And since then, the government of Uganda has launched several initiatives to address equity and efficiency. And we began by decentralizing health services to the local governments with the hope that it would take services closer to the people. Well, whereas it has taken services closer to the people, it has not addressed the issue of access to quality services and services that are readily available, because it is compounded by a number of challenges like lack of health workers and also unavailability of commodities. We also developed a comprehensive health sector policy and strategy that was based on a sector-wide approach in health, and primary health care grant subsidies were provided to private not-for-profit providers. We abolished user fees in public health facilities in 2001, and we established the village health teams to link the facilities to the communities and to ensure that the communities are mobilized to demand for services. This has to some extent worked, but then, as I said, there are still many challenges. And so, as we work on this roadmap to universal health coverage that we have drafted, and we are currently debating it with many stakeholders, there are many issues that as a country we need to address. And I would just like to mention 4 of them. The first is expanding equitable access to comprehensive, quality and people-centered health services, strengthening the health system stewardship and governance, increasing and improving financing with equity and efficiency, and advancing towards the elimination of direct payment that constitutes a barrier to access at the point of service. And the 4th is strengthening intersectoral action to address social, environmental, economic, and cultural determinants of health. And so I'll just mention a few areas in what we are now currently doing in our journey. First, we have developed a 10-year health financing strategy, 2016 to 2025, to facilitate the attainment of universal health coverage by making available required resources for delivery of an essential package of services for Uganda. That health financing strategy serves as an instrument for resource mobilization at all levels, steering health system investments in the correct direction, and providing the basis for aligning resources and creating opportunities for efficiency gains in the health sector. And one of the strategic interventions in the health financing strategy is the strategic purchasing using results-based financing approach. And in this approach, we have secured a loan to begin with and also a grant from the Global Financing Facility to make services available, especially for mothers and children, at a very affordable cost, time when they need it, and for them to also to demand for services when they need it. At the same time, to motivate health workers, recruit more health workers, and ensure that they are available. The second will be the introduction of the National Health Insurance Scheme, whose bill is already before Parliament for debate. And the health insurance scheme aims at ensuring that everyone is enrolled onto an insurance scheme, whether it is social, commercial, or community. We are also revising our community health extension worker policy and introducing a new one where the community health extension workers will be paid as part of the health workforce to ensure that the linkage between the community and the health facility runs smoothly, and as well as addressing public health. So those are some of the few steps we are undertaking. But like I said, the journey is not easy. The patients want answers immediately, and we can only do this when we listen to them, plan together with them, and draw the roadmap together. I thank you.
Okay, well, with that, I would love to thank each of our introductory speakers, and then invite up to the stage our moderator for today's panel, who is Dr. Ashish Jha of the Harvard Global Health Institute. I would love to invite all of the panelists up to join Dr. Jha on the stage.
Thanks. Appreciate it. You bet. Good Good morning, everybody. So as the panelists come up, I just want to make a couple of quick remarks to just as we get started and to frame this panel discussion. As you heard from the Secretary, as you heard from our previous speakers, and I think as you've been hearing all week, the bottom line is that there is no one pathway to getting to universal health coverage. And even if you look at high-income countries that have done a remarkably good job of getting to universal health coverage, I think there are a couple of points worth noting. We had a session a couple of days ago on the issue of quality and effective universal health coverage, and one of the speakers talked about how 70 years into the NHS experiment, there are still struggles, there are still challenges, so this really is a journey that never ends. It is not a destination that somehow we will get to universal health coverage. It is a constant, ongoing challenge. The second key point, I think, is that there is no one way to get there. So if you look at this country where we are right now, Switzerland has universal health coverage, its model looks very different than the model of the UK, which looks different than the model in Germany, which looks different than the model in Canada. And all of that is a reminder that there are lots of different ways of getting there, but also that each country comes up with a unique solution that fits its needs, its politics, its people, its history, its culture, and there is no single approach that we can take to achieving universal health coverage. That's, I think, one of the key lessons that comes out of what we see as you look around the world. Let me quickly introduce our speakers. And actually, what I'm going to do is, what I might actually do, just because everybody has access to these bios, so I am not going to get into any details on bios. We're going to keep it short. And maybe we will start here and just go down. And the way that we're going to run this is I'm going to ask each person to just say about 3 to 4 minutes of remarks, and then after that, I will go sit down and we'll just moderate a discussion. We will pretty quickly open it up to the audience because it's always more fun when we have a robust discussion. But what you will hear from the 4 speakers that we have lined up is if you think about getting to universal health coverage, there are 2 sets of broad issues. There are many issues, but 2 sets of broad issues, right? One is around financing. How do we finance this whole effort? And then the second is around delivery. Even if you have the money, how do we actually make sure that people get the care they need in a way that's accessible, useful, high quality? And the panel is going to try to tackle both of these issues together because in some ways, these are 2 separate issues that need to be integrated. Maybe with that, we will start here. If you want to, yeah, please.
Okay, thank you very much. There might be many diverse pathways and partnerships, but what I hope we all have is a common destination. And I think we can all agree that the common destination we have are the Sustainable Development Goals. Those are our goals. Now, for us, the UHC is a means to those goals. And there are many pathways. I would argue for a pro-poor, pro-equity pathway. We just heard from the Minister of Health from Uganda, which is, we have a lot to learn from Uganda, how you indeed link the financing and the programming. And that's what I think is so valuable to learn from Uganda. Now, our task is made easy because in UHC we have 3 dimensions, right? We have the, how do you first of all define your package or your interventions and the service delivery modalities? And if we all look at where we lag behind from the MDG era moving into the SDG era, it's really services for women, children, and adolescents. So if we allow countries to prioritize based on the local context, you will find if they prioritize across the life cycle, pregnancy, birth, early years, adolescence, across reproductive, maternal, and newborn, child health and nutrition, adolescent health and nutrition, you do not need to earmark your pathway to UHC. It's so clear where the big gaps are. And since we are asked to talk real, we are fortunate now in the GFF that we have almost 3 years, so we know what countries are doing. Countries are prioritizing family planning. They are prioritizing quality of care for mothers and newborn. They are prioritizing nutrition intervention in early years, and they really care about their adolescents. So that's number 1, support one priority set of interventions. Secondly, according to that beautiful UHC cube that I'm sure you all have in your mind, the other dimension is how do we reach those that didn't access services today? That's our concern. And that's why we hope we are shifting the paradigm, looking at the front line first. And I know we are many like-minded here who says, okay, who were the neglected populations? Pregnant women, young children, adolescents. Where are they? They are in communities that haven't been reached. So how do we really steer investments towards those who haven't been reached? And for us, it's so encouraging. Again, if countries are allowed to prioritize and we all align, they will identify those parts of the countries where population are left behind. That's why the GFF support the northwestern part of Cameroon, because the government of Cameroon knows that that's where maternal mortality has not gone down. That's why in Nigeria, the first disbursement was towards the northeast. That's why DRC, where we now see the epicenter, so that of the Ebola epidemic, where they chose to focus. So defining the package, reaching those who haven't been reached, and thirdly, link it to financing. And there we have so many exciting new instruments that countries are looking at. How do we mobilize domestic resources? You can link your disbursements linked indicators to maintaining your budget allocation for health, or even increasing it, as Mozambique's disbursement linked indicators show. Tanzania has made the same choice. One of their disbursement-linked indicators that so many are behind now, not just GFF and the World Bank, but the US government and several other governments, is really looking at not just achieving short-term goals, but putting the financing behind and actually linking it to performance at the most remote facility level, district level, but also at the national level, maintaining a focus. You can buy down interests so that countries with huge equity gaps can stay engaged in health. And you can use many other exciting instruments to draw in private capital, domestic resources, align partners, so we don't each take our own route in a country. Let's take one pathway in the country, a country-driven pathway to UHC and align ourselves. So I think we have great opportunities to link financing with priorities if we agree to support a country-driven process. And that's what we are trying to do through the GFF with partners, many here in the room.
Great, thank you. So So country-specific solutions, focusing on specific populations, the vulnerable, using equity as a guiding principle, defining a set of packages. But I think the part to me that's most striking and most important is the idea that we have a lot more innovative tools and instruments than we've had in the past. And so we don't have to start with a simplistic approach of we must finance it in this following way. That's very helpful. Thank you. Barbara, please. Thank you.
Thank you. Good morning, everybody. I want to talk about something different, but related, about people, about human resources for health. That's the focus that IntraHealth has in its work. And of course, people represent generally the second biggest bill for any minister. Listening to these discussions and reflecting that I've been listening to such discussions roughly since the earth was cooling, trying to reflect on how we reached the last 20%, you know, it's tempting sometimes to think, oh, not again. It's like PHC, UHC, SDGs, MDGs, you know. And as
it's always three-letter acronyms.
It is, I know. It's because we can't remember more than that. But as our friend says here, we have to, you know, move beyond that. And that is never more true than when you're dealing with people. And although each country context is different, what I would say is that it's the people, the human resources, that unites us all, that makes us more alike than different. And there is absolutely no reason why somebody living in Burkina Faso would like to go and work in a dirty clinic with no equipment, no beds, and no companions. There's no more reason why somebody there would like to do that than I would like to do it, or than you would like to do it. And that, I think, gives us an approach, that thought gives us an approach to human resources for health that we can be united in looking for solutions, I would like to hope. So I just want to tell you about 3 things that IntraHealth has done, which I think are relevant to this discussion. The first is, as you were saying, about bringing new innovations, about bringing innovation and new solutions to what there is. What we've done is we've used digital technology to start counting health workers. And that's very important because you'll never reach those people in remote areas if they don't have a health worker of some description. So, you know, we now have GPS. We can now go and track them. We can put them in their clinics. We know where they are. We know, we should know, you know, how old they are, how long they've been there. Because that's another thing that, you know, your average health worker does not want to be forgotten for 10 years in this awful place with no people and no internet. We'd hate it, and so do they. So knowing where they are, who they are, how long they've been there is very important. And we've brought our IRIS tools to that, and we're still developing them to help countries plan and manage their health workforce. So that's the first thing. The second thing is related to the whole health workforce pipeline. You have to attract them in. So there has to be people coming through school who want to go and be health workers. So we have to work across sectors. You know, you can't just be stuck in your silo. You've got to look at who's coming through that education pathway, the girls and the boys, and who's going to go into health work. So the whole health pipeline is important, working across sectors. And then when they come into the workforce, you've got to keep them. Otherwise, they're going to migrate somewhere where they get more money or better conditions, or they can work better. So we have to think about that. And as Jim Campbell says, we have to offer decent work, decent conditions, decent pay, and incentives for them to be where they're, you know, where they're going. So they've got to have a road so they can get out. It's no good dumping somebody when they can't get out for the next 5 years. So we've got to look at the whole pipeline, recruiting, retention, and then when they retire, and what sort of benefits we give them. All of those things are important. They're expensive for ministers, but unless we address them, we will be back in this room, well, you will, I won't, in 10 years' time, talking about this again. And the third quick point is that we had a very exciting scheme in Kenya, which was a public-private partnership, the Afya Elimu Fund. It was fantastic. We managed to get buy-in from banks and from the government to set up a revolving fund that keeps people in education, health workers in education. It's really transformed the experience of some health workers. And on our website, we do have stories about that. So these innovative financing models are possible. We just have to have the will to go and find them and to implement them. Thank you.
Great. Those are really helpful, helpful way to get us started, and a reminder that my mic turned off. Sorry about that. Hopefully you all heard that. Let me go next to Ken Mugumya from Living Good.
Thank you. And can you hear me now? Yes. I thought I was very loud. Yeah. So thank you so much. Allow me to say thank you to my minister. You know, every time she talks, I don't look at her as a physician. I look at her as a community health worker. She makes us proud, so thank you so much for your remarks. And allow me to quote one important lady, Professor Miriam Were, a renowned community health ambassador, who once told me that universal health coverage will not happen if it doesn't happen at the community. So as we think about universal health coverage, let's take a back step and think more about the community. And us at Living Goods, we believe that the way to universal health coverage is through high-impact, low-cost, integrated community health systems. We all know that more than 80% reported morbidity for children under 5 in Africa is attributed to preventable conditions. And it is undeniable that the people best placed to prevent these conditions are the community themselves and the community health workers. But they need to be well trained, they need to be well supervised, and they need to be well motivated. There is always need for commitment to ensure a world where every mother and every child enjoys access to basic health services within their community. So in partnership with governments, us as Living Goods, we have recruited, trained, and equipped more than 6,000 community health workers who go door to door, educating, diagnosing, managing child diseases, and supporting pregnant mothers without forgetting referrals to the nearest health facilities. And our model of implementation has showed that child mortality can be reduced by slightly over 20% for less than $2 per person served. We are continuing to innovate to increase the impact and scalability so that governments everywhere can deliver high-impact, cost-effective community health interventions. And when we take a back step and think about the universal health coverage, I think we need to think about 3 things: financing, managing our workforce, and improving the quality of care. We can't do all this without data. Without data, I don't think we'll make any progress. And at Living Goods, we do believe in simple but powerful tools that we use to work with our community health workers. We equip them with Android phones, and we make sure all the 6,000, we make sure they're well-trained, supervised, and they have that mini doctor within their, within their phones to make the right decisions. Going back to financing, we all know that high-quality data can attract new investment in community health by demonstrating that it is delivering outcomes. We are looking at increased results-based financing where investors, and these investors could be government or governments, it could be donors, it could be impact investors that contract outcomes from service providers to ensure accountability and results and increase the cost effectiveness. But we've also taken a back step, and we have realized that for us to make that huge progress, that ambitious step that we want, countries need to be supported to make country-specific investment cases for community health. We need to know what all these implementing partners, all the donors, and even governments, how much they have invested into community health. Then we understand the gap. How much do we really need to cover? Then we think about collaboration, coordination, and all that. Going back to management, large scale and often volunteer health workers are increasing day in, day out. How are we going to manage them if we don't use simple solutions? I'm glad IntraHealth has talked about digital health solutions. We need to know how many community health workers we have there in the field and the supervisors so that managers can be able to track the kind of impact that is being made at the community level. So we equip our managers with dashboards, and through the dashboards, they are able to see the data that comes in from the community, what a community health worker is doing at that particular time. It's on-time data, and we have worked closely with Ministry of health in Uganda and Kenya to make sure this is successful. So from our experience, supportive supervision, continuous healthcare education are the right tools being in place. It's always important as financial incentives being thought through to support this when they have, the necessary data of the number of community health workers that are in the community. But financial incentives need to be paid based on the work being done by community health workers. Of course, we know community health workers are human. Some will actually go and sit under the tree without doing anything and come back and say, we need to be paid. So we need to be careful, and we know with technology, all that can be solved. The third and last component I want to talk about is quality of care and accountability. Most community health workers need education. We all know that most of them are not highly educated. So as a result, they need guidance on their daily routine. The mobile application provides a standard workflows to diagnose a sick child, for example, every time, and thus improve on the quality and the consistency of the diagnosis. And the quality of supervision can be monitored through standardized supervisory processes that are technologically driven, and that provides supervisors with live data, as I had actually mentioned. So we all know that there is no one size that will suit or fit every situation. Let's think about tailoring our interventions to communities that we serve, to the governments that we serve, working with the governments, the local leadership, because we tend to focus on ministers. Leadership comes from the top and goes to the community. So let's think national, subnational, and the community to create that impact so that we can achieve universal health coverage. Thank you.
Great, thank you. And as we get to when we get to the questions in a few minutes, one of the things that I want to touch on is a recurring theme of how digitization really opens up new opportunities for accountability, for quality, for performance management, something that both Barbara and Kenneth both alluded to. Angela Gichaga, who's the CEO of the Financing Alliance for Health, thank you again for being here. And, yeah,
good morning, everyone. Good morning, everybody. As you've heard, my name is Angela, and it's a pleasure to be here to speak about financing, of course, as we speak about universal health coverage, but also our ethos as the Financing Alliance for Health in achieving universal health coverage, using community health workers as a strong building block for primary health care, which then obviously is a pathway towards universal health coverage. Just on the theme of this conversation, and we truly believe in partnerships at the Financing Alliance for Health. Obviously, by virtue of our name, we are an alliance, so we're formed out of partnerships between different organizations that truly believe in achievement of universal health coverage by strengthening primary health care. In the way we work, we believe in partnerships, and so we partner with governments to help them deploy at scale community health systems across different countries. In terms of how we get the resources for these systems, again, a partnership is very important. As a Financing Alliance for Health, our team serves governments, ministries of health, but because we know there's social determinants of health and the different factors that affect health, we also work with ministries of finance, because perhaps to Barbara's point, we've been talking about healthcare financing for many years, and maybe it's because we are talking amongst ourselves in health, and we know health. We may not be so good with the financing and the resources. So how do we bring in those players who understand resources, who understand financing and funding, and how to access resources. So we work with ministries of health and finance in countries, as well as other line ministries, because again, social determinants of health, there are issues around sanitation, and sometimes that is catered for by a different government department, and we need to make sure that they're all involved in the conversations around strong primary healthcare systems. And our role is to support governments to, one, understand the resource need they have to achieve universal health coverage based on our lens focusing on community health systems. So how much does their community health system cost? Supporting them do comprehensive costing, and then developing investment cases. Why do we do this? Because historically, health has been seen as a cost center. But our team has, and many people in the space have actually been able to demonstrate that health is an investment. There is a return on investment. There's an economic return on investment. And specifically for community health systems, our team demonstrated the 10-to-1 return on investment economically. But there is also our social return on investment, the empowerment that comes from giving the community a strong role to participate in their own health journey. They're no longer just recipients of healthcare. They should have a really strong role in determining the kind of healthcare they want to access, how they access that healthcare, and how they give feedback to that particular system. And then, of course, there's also the health returns on the investment to community health systems. So if for a country, majority of your deaths are from preventable causes, perhaps then you should be actually making significant investments where you can prevent the disease actually coming to play. So that's our principle. In terms of how we support governments is they now know their resource needs. Then we need to understand, okay, what's the true funding gap? What is the true gap? Again, based on partnerships, we realize that every person, every player has a role to play. And how we look at it is, if we now know that, for example, a particular community health system is going to cost X amount of dollars, what role does the government play? So the first thing is thinking, okay, domestic resource mobilization. And just as Mariam has mentioned, over and above coordinating, over and above showing leadership and putting policies in place, we strongly believe that for sustainability of systems, there's a role that domestic resources needs to play in putting systems, getting systems up and running. Secondly, who are the other players in this space, and how can we crowd in those particular players in a way that is value add and not fragmenting financing. We did some work with our friends and colleagues at USAID and Dalberg, and we were able to demonstrate that in sub-Saharan Africa, about $3 billion USD is required every year for at-scale community health systems, and what that means is there's a role to play by different players to contribute to this $3 billion USD. Right now, about $1 billion is in the space, and that is already significantly fragmented. So we're not actually building optimal systems that will help us get to universal health coverage. So what role do we have to play to make sure that that's achieved? For financing, a couple of things. One, we've also realized that governments obviously have a large order of magnitude of need in terms of financing. And sometimes there are solutions out there in existence that governments just need to have their awareness on how to tap into those resources. So it's not always going back to the drawing board and coming up with a new innovative instrument. Sometimes it's just helping create that awareness by governments and folks in this space on what is existent for them to tap into. That said, there may be instruments available, but they may not be suitable, as my colleagues have said, to the local country context. So how do we then partner with governments as well as all the players in the space to tailor make solutions that will be suitable for the different and varied country settings and requirements. And so what we've done as a team is with our partners, McKinsey, we came up with the Community Health Financing Compendium, and this is basically a compendium and a collation of all revenue-generating sources of financing for primary healthcare, specifically with a lens on community health systems, of existence instruments, revenue-generating, so growing the pie, making additional money to the space as opposed to just moving money around. And that was across blended financing and grants and debt conversion options, because of course some of the countries we serve have limited debt capacity and fiscal space, and across a number of categories. And I'd encourage the folks in this room to just go through that, because when we do engage certain countries, we do find potential avenues for them and pathways for them for financing from just existent instruments. For other countries, we are actually working with some of the DFIs to design instruments that could front load the finances at the order of magnitude that countries need, so hundreds of millions of USD over 5+ years, mechanisms that have as Mariam was referring to buy down mechanism. So it's a concessional upfronting of funding that, based on performance, which is again Kenneth has mentioned, governments are able to access tap into the capital markets, access concessional funding, and as they meet targets, the interest rates are brought down, and so then a country is able to access not just the order of magnitude of finances they need, but at the time they need. We working closely again with governments. Some of the communication we get is that they do get funding, but they're asking for 100 million, they get 5 million. They're not able to implement at scale, and so they're not able to have the impact that they need to have. And then now they're being held accountable for impact that they couldn't have because they didn't have the money that they needed. So if maybe we upfront the money that they need, then they're able to implement at scale and meet the target so that they can have the impact. So I'll pause there, because I'm sure there are always riveting questions around financing and accessing funds, and I'm hoping that we can all learn together. Thank you.
Thank you very much. So I'm going to start off with a couple of questions for the panel, and then I'll open it up to the audience. And my first question is both to Miriam and to Angela, and then I'll come back to Barbara and Kenneth in a second. But the question for both of you is, so we've heard a lot about innovative approaches and kind of trying to move beyond sort of old standard models for how we finance healthcare to these new approaches, and they are exciting and they're far more effective in terms of mobilizing resources. But one of the challenges, and Kenneth alluded to this a bit in his comments about quality, is that a lot of healthcare financing has still focused on inputs, number of community health workers. While that's important and it's easy to measure, ultimately what we care about is the outputs, right, in terms of how much health gains are we achieving. So help us sort of think about, as you have worked in this space and as you have thought about new instruments, new approaches, how do we tie in better health outcomes, or sort of the more, and I know there's the results-based financing as a catch-all term, but how have you thought about that in terms of linking what we ultimately want to achieve with these new instruments and new approaches? Miriam, if you want to go first, and then.
I'm really glad that you're asking that question, because that is the change that has to happen towards outcome-driven investments. If we all agree on outcomes, and those outcomes, and I want to link to what Barbara said, is about people's outcomes. What are the survival, health, nutrition, and well-being of people? Then you'd shift the whole investments at the community level. So honestly, if you put a dollar sign to that, we're talking about 33 billion is the gap across, the health, well-being, and survival of women, children, adolescents. And the interesting thing is, if we're talking 33 billion a year in gap, then clearly there's no way we can continue to do business as usual. We have to do catalytic financing, which means that you use, as we do, modest resources to mobilize domestic resources, to align bilateral and other multilateral financing around one investment case. We cannot have, 10, 20 unfinanced, costed action plans that the world has right now. There is a costed action plan for every intervention, for every condition. So rethinking around people, outcomes, and aligning ourselves, domestic resources, crowd in private capital, bring in all the various sources, because ODA is just a sliver, small size of the money available to us. There are remittances, direct private investments, there are capital, domestic resources, and if we can get all of that behind these investment cases that we all refer to, and we're not talking about 10 investment cases, we're talking about one country-driven investment case. Then we can have the technologies and the interventions aligned to that. And that's why I think, Barbara, my only how I want to extend to what you say, it's about the health provider, but it's also, of course, about the health users. So if we look at the users and the providers and their interface, that's the power of the future. And without doing that and shifting the demand and supply, the user and the provider, and also think about, as you said, how do you incentivize the providers at the front line, but how do you also then build on that capital, the human capital? And that's what's new this year. The economists will tell you that of all the things we can invest in, the best, smartest investments is the investment in human capital. It is in women, children, adolescents, men, husbands, but particularly I would say around birth, early years and adolescence. That's the investment in wealth and growth. And that's why we are in such a solid ground, all of us here, to really invest in what you talked about, people.
No, I couldn't agree more. And it's true. We need to focus financing on getting to outcomes. And also just to build on that and to take a different tangent also is, when you're implementing a system at scale, there's this issue around time, right? And you need time to get to outcomes. If you're going to upfront, let's say, for example, 500 million USD to a country over 25 years, perhaps you have to think about, do you want to wait 25 years to make sure that we have used the money well, right? So I think even as we're thinking about metrics, even as we're thinking about metrics, and we are outcome focused, we need to understand that there's a process to impact, right? And along the process to impact, how do we then identify the appropriate metrics along that process to impact? So yes, we are outcome focused when we are financing, and we want reduction of mortality, and we want reduction of morbidity, and we can measure maternal deaths every year, but we'll have to wait 10 years to get maternal mortality. You understand what I'm trying to say? So then how do we make sure that appropriately across the timeline and process for impact, we identify the right metrics for governments to so that we can be able to say, okay, governments, you're on track, governments, you're falling behind, governments, you're actually performing above what we had agreed. And so yes, there are outcome-based financing, but as along the point, you may have to say, look, in the first year, we had for example, in Uganda, we have a new policy on community health extension workers. And so in the first year, we'll be training them, and we'll be getting them on board, and so at that point, it will be challenging to measure the impact of a new cadre of staff, but there are metrics that we can attach to say that the government is on track to achieving the outcome in the long run. So yes, we are outcome focused, we are outcome focused in the timeline, but there are different metrics along the process of impact that we can also tap into. Thank you.
Great, thank you. And a reminder that while we want to be outcomes driven, we have to be practical about along the way, how do we track progress so that we don't have to wait 15 years to know whether something worked or not, and then go back and redo it. Barbara, Kenneth, I was going to ask, both of you alluded to the issue of digital technology, data, dashboards, it strikes me that that is the biggest innovation coming from outside the health system, right? Like the world is changing when it comes to digital technology, the availability of data, availability of information. Barbara, maybe if you could start, how should that change the way we think about what kind of workforce we need, and how we use our workforce, how we retain our workforce? How does digital technology, beyond, of course, being able to sort of track people's performance, et cetera, how do you see the advent of digital technology and the growth in it really changing that? And Kenneth, if you could talk about that as well after Barbara does, that would be great.
Thank you so much. Thank you for the question. I think we're standing on the edge of a big opportunity here. And I want to sort of pull us back to this sort of systems concept of simple, complicated, and complex. And I have used this in looking at task shifting or task sharing. So a simple task would be something like giving an injection. It's pretty simple. You can teach other people how to do it because it has set tasks, you know, and there's a protocol that you can use. Something complicated would involve several of those processes. So it might, you know, it might be like delivering a baby. Delivering a baby is very complicated, but you can learn how to do it because there are certain expected stages. When it gets complex is when things go wrong, if you're doing something like delivering a baby, or if the whole situation, like, for example, palliative care, would be a complex intervention because it's psychological, it's physical, it's to do with pharmacy. So it's really important when you're looking, I think, at digital health support tools that you understand that process. You can use digital tools to teach people and support people to do simple and complicated things when they're away from you. It's a lot more difficult to support them to do complex things because, you know, sometimes you have to have judgment. I used to work as a nurse practitioner and I used to teach nurse practitioners, and, you know, you have to teach them that you can do certain things based on protocols and what you know, but there comes a point at which you have to know what's going on and how you manage that. So I think it's important that we don't kind of jump into this idea that, you know, we can have telemedicine and supportive things and, you know, some poor community health worker with 6 weeks training can do open heart surgery in the remote Badlands. You know, I mean, we shouldn't be thinking of that. And I'm very minded of something Annette Kennedy said at the ICN lunch. She said, I want to see a day when we can all go to, you know, the smallest, poorest country and get the same quality healthcare as we get in Switzerland. And I want to see that day too. So we shouldn't be looking for solutions that don't provide the best quality healthcare. But having said that, there's lots of ways that we can use what we're inventing here in the rich countries to support health workers, both to learn, you know, by having low-dose learning modules that can be delivered remotely, and also by just-in-time information to support their decision-making.
That's great. And the key part of that, it strikes me, there is either this nihilism of, oh, it's all hype, or this sort of glorified, as you said, in 6 weeks, everybody's doing cardiac surgery. And the framework of simple, complicated, and complex is very powerful in terms of where digital technology can clearly play a role, right, and where it is going to have a much harder time having a big impact. Yes. How have you thought about this? And let me actually add one more flavor to your question, if you don't mind.
Yes.
Which is, it has struck me that we have been talking about community health workers for many years, and yet in the last 2, 3, 4 years, I feel like the conversation has shifted, and the focus, the energy behind community health workers, the community health workforce, really being at the front line, has become, I don't know, just much more, I think, central to our approaches. And I'm wondering if you can comment on whether you see that shift and whether you think, what has enabled that? And to what extent has technology enabled this idea that we can have community health workforce as a really central part of achieving UHC?
Thank you, Dr. Jaya. I would like to start by talking about a mobile phone. About 10 years ago, in my country, Uganda, it was pretty hard to own a smartphone. It was pretty expensive. But as I speak now, you can actually walk into a shop and get a smartphone at a very cheap price. Do you agree with me? And imagine how the smartphone is changing the thinking around the world. To us, we are looking at how we are tweeting, maybe using it for emails, Facebook, mention it. But then at Living Goods, we felt we need to use the smartphone to actually speak about health-related issues. Not only using it to incentivize the community health worker, whom we know to so many they would not have afforded that, maybe at that particular time. But then we are looking at equipping this community health worker with a smartphone. Within the smartphone, she looks at it as a directory for all the information she needs to make sure she gives the ideal healthcare package. She looks at it as the only tool she can use other than running distances to the health facility to deliver a paper written on how many children and women she has actually seen in the community. This data can easily be accessed. We are looking at her gaining the confidence that she needs because she knows whatever she's been trained on is actually easily accessed with a smartphone. So let's take a back step and also think how this is helping in decision making. At national level, I think in relation to the point you're saying, the impact and the interest, we've been struggling. So many countries have been struggling with issues of knowing how much health care is provided at the community. And getting technology into all this, and we make sure we have timely data to help decision makers, has helped them to understand, wow, maybe we've been getting things not right, maybe not wrong, but we can actually do better if we used technology to communicate, because with the community health workers, they reach out to a big number of people who can't easily walk to the health facility that is sometimes not well equipped with the right, medicines and maybe staff. So we save all that and say, this is the data. This is what is happening at community level. So make informed decisions and let us put community health at the heart of everything that we are doing, because everything starts at the community. Thank you.
Thank you. So we're gonna, there we go, terrific. So we are gonna go to questions, and I see 5, 6, okay, here's how we're gonna do it. I'm gonna actually take 3 questions at a time, and then I'll have the panelists answer them. Then we'll go to 3 more questions, and we'll start there, 1, your number 2, and number 3. Just quickly introduce yourself, and then let's keep the questions short and simple so that we can have the panelists answer them, but please. Oh, we have mics.
Thank you. With Chatham House and the elders, just want to talk about the financing pathways to universal health coverage, and suggest that they're perhaps not quite as diverse as we think, and there are clearly pathways that do lead to universal health coverage and those that don't. And really, if you look at the definition of UHC, everyone getting the services they need with financial protection, it requires that the healthy, wealthy cross-subsidise the sick and the poor. We know this. So that really, by definition, means public financing. You can only reach UHC through public financing. And all the examples, be it France, Germany, Switzerland, UK, Thailand, it is public financing. I know here in Switzerland that sort of people are forced to take out private insurance, but the government controls everything. They control the rates. So really it is a publicly financed health system here. The one country that has patently failed to achieve this or understand this is the United States. You know, the United States went off in a completely different direction, based largely on private voluntary financing. And we've seen that with disastrous consequences, 18% of GDP spent on its health system. I mean, to be frank, it was astonishing to hear the Secretary stand there and defend the US health system. I mean, note he didn't stay for questions. You know, that's I'm sure I can't be the only person in the room thinking, because we know that the Trump administration is taking the US away from universal health coverage. The number of people uninsured is rocketing, and, you know, sort of poor people are going to die as a consequence. So I really do think that, you know, in discussions like this and advising governments, we should be showing them the wood for the trees and say it's all about public financing, different types of public financing. But further than that, I think there's a very important role for those of us interested in UHC to get involved in the US debates. You know, you're seeing Trump taking the US away from UHC, but there are politicians and movements in the United States now, in New York and California, trying to change things. So I think if we're serious about UHC, we should be engaging in the US debate, not only to help the health of Americans, but to stop this toxic ideology that is misleading other countries.
Great.
Thank you.
Thank you for your comment. I'd identify two other folks, especially if there are questions, that'd be great. Yeah.
Yeah, hi, Claire Blanchard from Save the Children. First of all, thanks to all the panelists, and also commending those that speak up against systems that generate more inequality. So thank you for that. I think very important. My main question is around, you know, to the panelists is, what are the main components in your view to sustainability building towards populations that are healthy and have well-being everywhere? And I think, you know, we've talked about innovative and adaptive financing, institutionalizing the role of community health workers. We haven't really talked about community ownership and meaningful participation of citizens and citizen-led accountability. I'd love to hear views on that. And the second part of that question is, how can we learn from southern countries? Because I think we have lost so much of our sense of community in northern countries, and I think we need to shift the dialogue from let us support southern countries and actually let's learn from them.
Hi, thank you to a wonderful panel. My name is Nadia Cobb. I'm with the University of Utah. And my question surrounds the community health system. And I love the fact that community health workers, there's a big push. But I think in my mind, I'd like to hear the panel answer to the fact that it's not just about a cadre of community health workers, it's about the system that they link into. And often those cadres are uncategorized. So clinical officers, medical assistants, public health officers, et cetera, they are the primary care providers at the front line, engaging with the community health workers and the teams, advanced practice nurses as well. And so I'd love to hear that discussion broaden into the actual system rather than a focus on the cadre. Thank you.
And I'm just going to start from Miriam and come down, and you don't have to answer all three of them. Just if you want to take on any of them, whether it's clearly a critical role for the public financing in any system, because at the end of the day, especially if you want to cover the poor, you need a mechanism that requires cross-subsidy from the rich, or keys to sustainability. I won't repeat the questions. Why don't you go ahead and start off, Miriam?
Yeah, I know the first one was a comment, but I do want to also just echo what you said. If we know that most, in the poorest parts of Africa, people pay out of pocket for their services. I think in the Sahel region, more than 45% pay out of pockets. So clearly that's not a pathway, a sustainable pathway to the SDGs. So again, we are all talking, I think, about sensible risk-sharing schemes, insurance schemes that are part of the whole discussion around domestic resources. Domestic resources isn't just about finding sin taxes and growing the pie. And you know, from what we currently are doing, in fact, looking at where we can bring in revenues, but it is about the fact that poor people are paying out of pockets and addressing that. I also think that I'm so glad you brought up the community health systems, because also the front lines right now is very fragmented. Cool ideas, digital tools, financing schemes. So how can we think systems around the community so that health worker that we care about has all the support and also becomes a professionalized cadre? How can we move from voluntary health workers to actually pay for frontline workers and making sure that they are fully equipped? If we talk about paying for performance, which is, by the way, how we are getting results in the most fragile part of countries right now, early results, is because it goes hand in hand with some kind of accountability mechanism. So thank you for bringing up the role of CSOs, community citizens, actually being clear about what those results and outcomes are that we're talking about and put the pressure on. Because when we say that it should be country-driven, it's government and civil society driving the process. So great, very helpful inputs.
Yes, I'm just going to focus on Nadia's question about community health systems. And of course, you're right. And this is really often the problem, isn't it, when you are asked to do something for a particular cadre, is that it's fine when people are working without a legal or policy framework, but once you start to implement a legal and policy framework, then everybody starts getting very edgy about that. So the advanced practice nurse would not be doing my job, would they, says the doctor. You know, it's that when these professional sensitivities start to kick in. But it's not good enough. And I think we really have to step up as a community and, you know, sort of tackle this. It obviously makes the best economic sense when everybody who's educated works to the top of their license. Clearly, because then you're using the human capital that you've invested in. And there are many barriers to people doing that. But, you know, what we tend to do is just ignore it as a community. I mean, I'm including myself in this, because it's so difficult to change. And that really brings me to Claire's question, which is about citizen participation. And, you know, the really hard issues are about governance and stewardship, in what Mariam's talking about, obviously. And again, it's something we're so reluctant to take on. But, you know, in a world where we put problems out on the internet and solve equations that have never been solved, we actually do it, surely there's a way of us thinking together about how to solve some of these fundamental issues.
Yes, local ownership. I think that is very important. In my remarks, I tried to talk about engaging the political leadership at all structures. As living goods, we've learned along the way that without the community accepting what you're providing, you'll not get anywhere. So through our selection processes of getting the right community health workers that we train, we engage the local leadership. We engage the influential people within the community. We talk to the families of these community health workers, because there are issues around gender-based violence. So we take it down to the family level and make sure there is appreciation and the value attached to the kind of work that we are actually doing. Then we also noticed that we need to close the loop. It's not all about community health work. We just need to make sure we work closely with the health facilities within the community. So when we are training our community health workers, we make sure that we visit the health facilities within the community. One, introduce the community health workers we are working with, but also give an opportunity for these community health workers to learn from the people, from the professionals who have been doing this work for years and years. Share the challenges, share the best practices, and see how best they can work with a wider community. So it's not all about the community health worker, but then it's about the community health worker working in a holistic way with a wider community and integrating the services with a broader health system. So, and I think we've got excellent lessons that we can actually share about that. Thank you.
Great. So the first was a comment, but I wanted to just add to that comment, and it's a valid comment, sir. The element of time, right? And yes, public financing is key for, especially looking at the order of magnitude that is required to achieve universal health coverage. The perspective is, how do we then use existent public financing to be catalytic to other sources of financing? How do we also allocate existing financing? So you do have public financing, it's not sufficient. So where do you use the public financing? Where can you use the private financing in an optimal way? And then how do you think over time to transition that responsibility? Because we are now at point time T, and then we're saying it's a journey to UHC, which is another time stamp, right? So if we're here and we want to get further along the journey, how do we use what we have to crowd in more money? How do we allocate that money efficiently across different, and based on sustainability, thinking of all these factors? Then at the end of the point time T, then we have probably a different mix of those two different sources of money, but are more sustainable and ensuring access and quality of care. So I agree with you, especially in the principle. It's just, again, the element of time and how do we make sure we get the right mix. And the second was around systems vis-a-vis focus on the care provider. Again, thinking of it as a continuum of care, right? And a continuum of care is, where do we say community health systems ends and primary health care system starts? How do we say, primary health care systems ends? And, it's a continuum of care. And I think sometimes it's a false dichotomy, and we introduce false boundaries. It's really a continuum of care. And I think the point we are making is around, yes, let's focus on the system. And we understand that everyone has their role to play. It doesn't mean community health systems and the workers who are within that system are not a stopgap measure. They have a role to play. It doesn't mean that if you have a community health worker, you don't need more nurses and more. No, that is not the point that is being made. There's a role that this specific cadre can play, and there's another role that this specific cadre cannot play. And let's recognize that we need to achieve the ideal ratios across the entire human resources for health spectrum, and focus on linking the systems more than trying to disaggregate the systems. And the third thing is around the role and ownership of communities, and this is one way, not just telling them, okay, we have brought these services to you and you're sick and you need this vaccine, but it's saying, look, can some members of your community be part of this whole patient journey, health experience? Nominate a couple of people from your community who you believe and you trust to come door to door to you to check up on you when you're pregnant, to follow up after you give birth, to give you health education. You nominate people who we can then provide skills with, and then we continue that continuum of care to the doorstep. We will not necessarily have a cardiothoracic surgeon leave a high-level tertiary hospital and go into someone's household on a regular basis. Let's understand it's a continuum of care, and we all have different people who can play a very important role across that continuum. Thank you.
Great. And I'm not sure I even want the cardiac surgeon going into people's homes. Not because it wouldn't be a good use of their time, but they're also probably not very good at it, right? So what we want them to do is focus on the operating room. Let me just very quickly comment, just I've spent the last 15 years studying the American healthcare system, and I think there are a couple of things that are I agree with the notion that there should be a debate, and I have, by the way, zero interest, actually less than zero interest in defending the Trump administration. But the American healthcare system is complicated in ways that if you don't understand and dig into that sort of next level, there's a lot of things that can be misunderstood. So let me just make a couple of quick points. About half of Americans are covered through public insurance. So public financing is a very substantial part of the American healthcare system. And it turns out, if you just look at the public side, no private insurance, but just the public side, it's about 8.5% of GDP. So just below the OECD average. So America has a publicly financed health system spending about 8.5% of its economy, funded fully by the government, it just manages to only cover half the population with that. So that's interesting. But that's interesting because it says that that's a problem. And the reason that that happens is because our primary care physicians get paid $250,000 a year. Our specialists get paid $600,000 a year. We have a very, and that's public and private. The only other thing I will say is that we're at about 91% coverage. So we're not at universal health coverage, but we're not at 70. And if the Affordable Care Act had been implemented, we would have probably gotten to about 96. So again, and the one big group that got left out, which America has a much larger proportion of than most European countries, certainly in the way that data are counted, is undocumented workers, illegal immigrants, whatever term you want to use. And most European statistics don't count in those people when they say we're at 99 or 100%. America does. So if you take that group out, we're probably around 93. This is not meant to defend the American system. It is just to say these things are complicated. And I think the notion of America doesn't have UHC, others do, true, but it's not just about public versus private financing. Each country really does struggle with a mix of these challenges. And I do believe that each country is going to come up with its own solution. That doesn't mean that we can't learn from each other. Let me stop being commenter, go back to being moderator, and let's take the next round of questions. And I see 1, 2, and then back there, the woman in the white as 3. I'm sorry, and then we'll try to do one more round after this, but yes.
Thank you. My name is Paul Lalvani. I'm the director of Empower School of Health. Our focus is on scalable, continuous learning to the last mile, focusing on getting basically a combination of coaching, leading, mentoring using digital and analog methods. I also lead the global platform on supply chain and access, and most of our discussions actually stop at the primary healthcare center. They don't go to the community health workers. It would be interesting to hear from Kenneth and Living Goods in terms of how you think of the supply chain and if you've mapped that out and what some of the challenges are, what some of the recommendations are.
Great, thank you. Right behind you.
Hello, thank you for the wonderful panel discussion. And my medical students from Taiwan. And as medical students, there are many chances that we can participate in voluntary clinic, which we provide short visit to remote areas. However, the establishment of sustainable primary health care can't be provided by this kind of short-term visit. So it's really a pity if we can organize this kind of diverse workforce. As Mrs. Barbara mentioned, sorry, as you mentioned, the tracking of workforce through digital tech. So is there any efforts undergoing to organize internationally the short-term medical services from different healthcare workforce? Okay. Thank you.
Great question. And then back there.
Hi, I'm Ava from the International Association of Dental Students. So within these conversations about UHC, very often dentists and oral care is left out, I feel at least so, as a young professional. And but I think, well, I guess it is largely to do with financing as well and incorporating the private sector, which you have mentioned before as well, which is very, very good. But one thing that all of the panelists have mentioned is actually ways how to incorporate oral care more. One is through the community health workers. The other is incorporating digital technologies, and I very, very much liked the sentence about prevention. So oral diseases mostly are related to prevention. So if you can put money and effort into prevention in case of digital technologies and also the community health workers, it's not much money needed, but it's a very, very big impact. So can you also maybe elaborate a bit on how oral care can be integrated into the overall sector and topic? Thank you.
Great. Let's, if we can just have brief answers. And I agree, oral care is just amazing that we've somehow decided that this part doesn't count. We finally have agreed that this part counts. It's taken a while, but mental health is finally in, kind of. Hey, little victories, but this part is still out. But Kenneth, since the first question came to you, just briefly on supply chain, and then if others could weigh in on the other issues. Yes.
Good. Maybe just to mention, whereas we think this part doesn't really count that much, our community health workers, they have a referral system embedded into this. Every time they realize there's something wrong, they have to refer to the nearest health facility. So they don't have to treat and diagnose everything, but they just have to use, so they are trained to use their intuition to actually know that this situation needs a health worker who is more trained than me. So our referral addresses the dental-related issues that are always silent. Going back to the supply chain issue, in Uganda, we have developed the community health supply chain strategy. It is still on its way to be operationalized. But then from Living Goods experience, we've worked to make sure we have our products nearest to the community health workers that we actually work with. So we have, I should say, an effective supply chain system. It is private, but then we are working closely with government to see how we can embed our best practices into the wider community health strategy that has been developed with the support from MSH. Thank you.
With all due respect to the chair, you took off the hat for a while, so I'm going to comment on what you talked about, if you don't mind, because it resonates, I think, with the rest of the discussion. We talked about how we should judge health systems by outcomes, right? Yeah. So for me, it's really fascinating if we look at outcomes in the US. Forget about costs and inputs. What's happening to maternal mortality rate? And if you then add what we also said here, not just outcomes, but look at gender, other income differentials. So first of all, maternal mortality rates is a very good thing to look at what's happening. And secondly, what you said about the part of, mental health. Yeah. Where are premature deaths happening in the US right now, and not just in the US, but in the Western world? Mm-hmm. Adolescent health is a phenomenon across mental health, adolescent mental health. And they are dying from depression, self-harm in the US, the injuries in some parts, and early pregnancies in others. So I do think we should judge all countries by outcomes, by income, by gender, by indigenous, or whatever is the vulnerability factor, and then we do not fare very well across the board.
Teaches me never, ever to speak up as...
Making more interesting.
Definitely not in this administration.
Thank you.
All right. I've been getting the signal that we are out of time, which is very unfortunate because this is a phenomenal panel, and I would like to go for another hour. But I think our host will not be very kind to me if we do. So let me actually, before we go to the next and couple of closing parts of this session, let's just take a minute and thank this panel for what I thought was an extremely rich discussion, getting beyond sort of the standard jargon that we often find ourselves in and getting into much more of the details of the solutions, because we all believe in UHC, but getting there is going to be extremely hard, and we will never get there because it is a constant journey. And innovation, thinking much more concretely about the front lines, all of that is going to be central to achieving what we want to achieve. And so, and these four individuals really are at the heart of that work. So let's give them a big round of applause. Oops. I'm going to bring up our next speaker. So if we want to, yeah. From here. So Sunil Kumar is from Jharkhand, which is right next to the state Bihar, where I was born and grew up. He's been working directly with community health workers. And for those of you who know India, Jharkhand, Bihar are really the poorest states of India, often the most dysfunctional, often the most challenging. And his work has really been at the forefront about thinking about solutions for using community health workers for driving improvements in health outcomes. And I am going to go sit over there and turn the floor over to Sunil. Thank you for being here.
Thank you. First of all, I would like to thank you for inviting me to share my field experience. The session was very enriching, and the issues and points discussed here I can take back with me in my work with ASA and community health worker in my home state Jharkhand, India. Some reflections from my field experience are, first one is participation in planning. In developing plans to increase community access to health services, we must involve community health worker in the planning process. Second one is training. ASAs in Jharkhand were trained to address maternal and child health services, but the ASAs and nurses were in large demand of NCDs to address. So we incorporated training to provide them prevention and monitoring services for the conditions like diabetes and hypertension. And this greatly improved the condition of the community health worker. And especially when they were given training through their mobile phones. So we need to include this kind of community input into our policies. Third one is data. So we have worked with Jharkhand government as well as Bihar government for setting up a web-based human resource information system, including all employee who is either contractual basis or regular basis. And based on this, they are analyzing their HR gaps as well as doing their rational deployment. But that time, government was not ready to include ASAs, that means community health worker, in that category, and we excluded to register them. But now, they as well as we are thinking that without them, we cannot analyze the actual HR gaps in any state or country. And finally, health workers cannot provide proper delivery of services to community if they do not have adequate supply of any equipment or drugs. I have often seen ASAs are lacking supplies in Jharkhand, like glucose strip to measure diabetes and hypertension, diabetes. In my view, listening to the needs of the community and providing career opportunity to community health workers is central to achieve universal health coverage. Thank you.
Thank you, Sunil, for bringing it home and the conversation we've had. And I do believe that we have had a frame shift in the global health community, understanding that community health workers are going to be not an important part, but a central part of achieving universal health coverage and getting what we want, which is for people to be able to access and get high quality care. And Sunil, your experience in Jharkhand in some of the most difficult areas with some of the biggest challenges has been nothing short of inspiring. So thank you for your comments. We are going to move to just some closing remarks, and this is a bio you don't have in your packet, so I'm going to take just 15 seconds to introduce Rudiger Kresch, who is the Director of Health Systems and Innovation for the World Health Organization. Before this role, he was a director of the Department of Ethics, Social Determinants of Health. Before that, working on ethics, equity, trade, and human rights. But one of the things that if you look through his bio, focusing on social determinants, focusing on all the things that happen outside of the healthcare system that influence health outcomes has been an important part of his work and his focus. And we are thrilled to have you here. Thank you for coming and joining us and saying a few closing remarks.
Thank you very much, Ashish, and thank you, Lois and the Global Health Council for bringing us here together. We've had quite a few discussions on universal health coverage in the past days and before, but what I want to say is it's so nice to see that we're all aligned when it comes to understanding universal health coverage. That is, that all people receive the services they need without facing financial hardship, and not only some. So this is good, and we're on the way to it. Now, we also need to understand, so I really like the panel, great for all the panelists. And I think we need to understand that universal health coverage and health systems are now, in many countries, the biggest economic driver. And it will go steeply up in many more countries. And with this comes very different interests, both outside of the healthcare system and inside of the healthcare system. So a challenge for all of us, whether in government or in civil society, in academia or elsewhere, will be to see that we're getting the systems right. And not fighting just for our constituencies, but seeing that there is a bigger whole. So, of course, we're in a lot of discussions with our colleagues working on disease-specific programs. And we're in a lot of discussions with our colleagues working on population-based programs. And within the health system, we're of course in contact with the health workers, the financing, the information, the governance, and all that. It's so important that we bring this all together. So when we talk, for instance, about the needs for funding, it is the whole, and it is not the individual. So we're not talking about just maternal and child health, but we'll have to look at the overall financial resources that we will need in order to drive health systems forward. And in this regard, we as WHO have developed the price tag. So what will it cost? And we've developed two scenarios, one more conservative, one more progressive one. And that means that we will need $136 to $371 billion a year until 2030. That is the price tag. Now, the good news is that 85% of all this will come from domestic funding. That is the big source. And I'm so glad about the discussion we had on, public, private, and whatever. But this is the price tag that it will take. And 85% of that sum will be coming from domestic funding. Now, it's all about reducing to the minimal the out-of-pocket spending. That is the most unjust way of health financing, because we don't have a way to negotiate what sort of we get for the services we pay for. So therefore, it's the 11 to 13 trillion US dollars that are spent every year at the moment, again with increasing figures, that we need to control, in terms of that we have the purchasing power as citizens on what we buy for this amount of money. And So I think people said, yes, every country will need a different pathway to UHC. We totally agree to that. Now, Tedros asked heads of state to come up with commitments during this assembly on 3 concrete commitments they will do in order to achieve UHC, and quite a few countries have actually followed this. Now, Gaia, I was because you're in the audience here, I was wondering whether perhaps we should think together, and with others as well, whether we should ask countries to come up with concrete pathways, as we've done for human resources for health in Recife, where we actually now 5 years later see that a huge amount of countries and partners have actually not only come up with their pathways and their commitments, but we can show concrete evidence that they have moved on that pathway. Right, so perhaps we could think together how we can ask member states to come up with those and partners to come up with those pathways much more concretely than just saying, okay, we will do something. And that brings me to my final remark, which is the accountability. I think we've and I so much liked your introduction. Exactly to the point. We have, for the past 15 years, been very good in advocacy work on UHC. And I think it's important that we continue this, because if we don't do advocacy, it will be forgotten. However, what are we concretely doing in countries and in the local communities? Lois, you had a great side event here on health security, which I was so honored to be here as well. And we looked at the frontline workers. These are the people who defend health security. And frontline workers are the people who actually deliver health services. So if we can look at the local to the global, the glocal, if you will, action on and concrete accountable activities towards UHC. We have indicators with the Global Program of Work number 13, which will be adopted as we speak. It's on the agenda in Committee A right now, and we just had a couple of more partners to speak up, but we haven't heard any offenders to the resolution. So we will take it that the Global Program of Work will be accepted, and that's not only for the work of the Secretariat in WHO, but it's for all member states. And with this goes very clear indicators on the 1 billion on universal health coverage more, on the 1 billion people being more saved from emergencies, and 1 billion more that enjoy better health. And so, therefore, perhaps we can take and identify the levels of accountability for each of us, right? What do we have? What sort of accountability do we have at WHO in the Secretariat? What sort of accountability do member states and governments have? What sort of accountability do we have in academia, in civil society, and all the players? So together, then, we will move. So, to close, it's getting aligned on the concepts. Let us not divide ourselves for universal health coverage. It's not the one disease, it's not the one population group. It's all of us, it's the health systems that need to play. And then let's look at the accountability lines. Wherever we are, we have a role to play. Thank you so much for this today.
Thank you, Rudiger, and thank you to each of our wonderful speakers and our excellent moderator, Ashish. I really very much enjoyed that conversation. I'm just here to officially end things for this morning and once again acknowledge our co-hosts, Living Goods, Frontline Health Workers, IntraHealth International, as well as Devex. I certainly have enjoyed the conversation. I hope you all have as well. Thanks also to our online audience who has joined us today. Hopefully we can continue to have these types of robust discussions in the months and years to come. Take care.